Welcome back to my channel. The term respiratory failure is used when pulmonary gas exchange fails to maintain a normal ideal oxygenation and carbon dioxide levels. Type 1 respiratory failure occurs when respiratory system cannot provide adequate oxygen to body, leading to hypoxia, whereas type 2 respiratory failure occurs when respiratory system cannot sufficiently remove carbon dioxide from the body, leading to hypercapnia. The respiratory failure can be classified based on chronicity, that is acute, chronic and acute on chronic respiratory failure. If either type of respiratory failure is not identified and treated early, it will become life-threatening, leading to respiratory arrest, coma and death. The formulas for calculating alveolar arterial gradient and alveolar gas equation are as follows. These concepts are helpful in understanding the pathophysiology of respiratory failure. Alveolar arterial gradient is calculated by subtracting the alveolar partial pressure of oxygen and arterial partial pressure of oxygen. Next, alveolar gas equation. These equations estimate the partial pressure of oxygen in the alveoli. Now let's come to pathophysiology of type 1 respiratory failure. The distinguishing characteristics of type 1 respiratory failure is a partial pressure of oxygen PaO2, that is PaO2. is less than 60 mm of Hg with normal or decreased partial pressure of carbon dioxide, that is PaCO2. Depending on the cause of hypoxemia, the alveolar arterial gradient may be normal or increased. Etiology of type 1 respiratory failure with a normal alveolar arterial gradient include alveolar hypoventilation, low atmospheric pressure. Etiology for type 1 respiratory failure with increased alveolar arterial gradient include diffusion defect, in which the structural changes to the alveolar component of the alveolar capillary interface, such as decreased surface area or increased thickness. This may result in diffusion defect across the membrane. This diffusion defect usually seen in conditions like emphysema and interstitial lung disease. Ventilation perfusion. Normally, the alveolar gas composition depends on the balance of alveolar ventilation and pulmonary capillary blood flow that occurs at alveolar capillary interface. When perfectly matched, the ventilation perfusion ratio is equal to 1. Ventilation perfusion is most common type of type 1 respiratory failure, which is seen in acute respiratory distress syndrome, chronic obstructive pulmonary disease and congestive heart failure and pulmonary embolism. Right to left shunt. The absence of gas exchange at the alveolar capillary interface represent as a true shunt. The shunt occurs when the ventilation perfusion ratio reaches to 0, which is seen in arteriovenous malformation, complete atelectasis, severe pneumonia and severe pulmonary edema. Now let's move towards the pathophysiology of type 2 respiratory failure. Hypercapnic respiratory failure is defined as an increase in arterial carbon dioxide level of more than 45 mm of Hg with pH of less than 7.35 due to respiratory pump failure and or increased carbon dioxide production. Respiratory pump is the compromised of the chest wall, the pulmonary parenchyma, the muscles of respiration as well as central and peripheral nervous system. The pump failure can be occur due to following causes, that is decreased central drive by sedatives and disease of the central nervous system. This may impair the respiratory drive and resulting into hypoventilation. Altered neuromuscular transmission, which is seen in diseases like myasthenia gravis, GBS, poliomyelitis, organophosphate poisoning, botulism and spinal cord injury. This can also result to respiratory pump failure. Chest wall and pleural disease and muscle abnormalities also lead to pump failure. Next, increased carbon dioxide production. Carbon dioxide is byproduct of oxidative metabolism and high CO2 production may occur due to fever, exercise, hyperalimentation, sepsis and thyrotoxicosis. Physical examination. While assessing the patient with respiratory failure, assess for use of accessory muscle use, altered mental status, dyspnea, fever, obesity and perceived lip breathing. In neck, check for jugular venous distension, lymphadenopathy and tracheal deviation. In chest, look for asymmetrical chest expansion, bronchial breath sound, crackles, wheeze, stridor, etc. In abdomen, look for hepatomegaly. In lower extremities, look for edema, peripheral cyanosis, and unilateral swelling. In upper extremities, look for digital clubbing, peripheral cyanosis, tobacco staining, and tumor. Evaluation and management. Arterial blood gas, that is ABG, is the gold standard for diagnosis of respiratory failure. Radiography. Various imaging tests are used to diagnose the respiratory failure such as chest X-ray, CT scan, MRI, and sonography. Pulse oximetry. Measurement of arterial oxygenation is measured through the pulse oximetry. Bronchoscopy, echocardiography, and pulmonary function tests may also be included in evaluating the respiratory failure. The treatment of respiratory failure should be directed towards the underlying cause while providing support with oxygenation and ventilation. The initial step in managing patient with acute respiratory failure should start by assessing the airway, breathing, and circulation. Supportive measures depend on the patent airway to maintain adequate oxygenation, ventilation, and correction of blood gas abnormalities. Number 1. Correction of hypoxemia. The goal is to maintain the adequate tissue oxygenation with maintaining of PaO2 level of 60 mm of Hg or arterial oxygen saturation about 90%. Oxygen can be delivered by several routes depending on clinical situation. Correction of hypercapnia and respiratory acidosis. This is achieved by providing ventilatory support. So, understanding respiratory failure is a first step towards saving life. Stay curious, stay prepared. Subscribe my channel for more such content.